thank you, Tactile, for having me here tonight. And I want to thank everyone who came out this evening to really be here with me. This is a time none of us have ever experienced. And, you know, typically I'd be showing you my disclosures here, which are important. And in the past, these were important because I was so excited, having started a consultancy business 3 years ago, that finally people wanted to hear about lymphedema. And I know some of the people here in the room tonight, virtually, have been on this journey with me for quite some time. But what's really important is to look at the t-shirt of my student. And he asked me, you know, to use this picture. Well, I asked him and he agreed. And I loved it because right now more than ever, we have to set our settings of determination and not having excuses, and certainly trying to minimize our fear as much as we can. So with that, about 2 months ago, I presented at a BC3 conference in Washington, DC, a bunch of breast surgeons and interdisciplinary. It was wonderful. And these were my learning objectives then. As you can see, I have now retitled them my pre-COVID-19 learning objectives because everything has changed. It's changed on a dime, and we have to be able to react to that. So I've redone these, and I'm trying to keep it simple again with the ABC motto. And that really is, we have to adapt. And that's not just us, but our patients. The believe is also for us and our patients and really the whole world, knowing that we can do something about this. And we're going to have to collaborate like never before. I was talking to a colleague, I hope who's here in the audience tonight, and we were just saying, you know, we've got to invent some new wheels, but let's invent one and not all of us try to invent the wheel, and let's try to do it together. So I'm hoping to weave this in through this talk tonight and try to write down any questions you may have throughout, so that at the end, when you can type the questions in, I'll be able to get to them. But first, I have to ask this question. It's one of the poll questions. It's going to be simple. You have about a minute to answer this. And how many of you were alive in 1989? So you can see the picture there. That's the wall coming down. And that actually is a chunk of wall that I have right here in my office. So right now, I just want to know, yes or no, how many of you were alive in 1989? And you may be saying, Maureen, why do you want to know that? Well, it's a nicer way of asking how old are some of you and how young are some of you? I want to get a sense of who we are in the audience. This is, as many broadcasters and late night TV hosts can tell you right now, talking into a camera screen is really challenging. The emotional connection that I'm not getting with you right now is hard for me. But this is just going to give me a little sense of who's there and also how to contextualize what we're going through right now. When I think of being just out of college, and I wasn't even a PT yet, hadn't even thought about PT school yet, but when that Berlin Wall came down, it was the first time in my life I really remembered feeling that the whole world was in this together, similar to how I feel right now with COVID-19. So I'm going to turn and kind of see what some of these results are. So, all right. So we have, I guessed this earlier today, about 75, 76% of us actually are over 31. That was what 89 would be. So for all of you who are older, you certainly remember that. For everyone younger, most people say that 9/11 was the thing that they really remember as that collective world kind of situation that occurred. And so I'm going to do a little more history here. So some of you who were not alive will not get this next reference, but for those of you in the audience who were alive in 89, excuse me, you'll know and be able to guess when this picture was taken. As we move into telehealth and telemedicine, we are going to have to be very good observers. So for those of you here who are probably starting to figure it out, I like to tell stories. In 1989, I actually graduated as an English major. And so right now, when I'm thinking ahead to where we're going, I'm thinking about what is the story that we're going to write. When I was 10 years old, that was in 1976, because that was the bicentennial, and that was another formative thing for me. Everything I owned was red, white, and blue with stars and stripes. And I thought, you know, as a 10-year-old, what did I want to do when I got older? And I knew I wanted to help people. And so right now, it makes me think of Mr. Rogers, right? And he said, when something bad is going on, he always told kids, look for the helpers. And I really think that's what we're doing here together. So With that, I had to throw this in with the Queen. It's only the 5th time in her 68-year reign that she's spoken to the people directly. And I feel like, that was so moving because we are afraid and we're not really sure what to do. We're going to Twitter, and I'm going to show you this Twitter thread to show you kind of these connections that we're making with Dr. Peter Mortimer, who's over in the UK, and Dr. Roxon, who's here in the States. They've been talking for years about how the lymphatic system is fundamentally important in so many different diseases, not just lymphedema, right, but cancer, infection, and immunity. And we used to say, gosh, we're done with those infectious diseases until now. So what's really wild is on this Twitter feed, and if Rich Severin, if anyone knows him, I want to meet him, a really brilliant guy, and did a great post the other night about how different what we're dealing with COVID-19 is. And it's not just a typical airway clearance problem, so we can't just throw a regular chest PT at it. And he gets down to this point, if you see around the 3rd one down, where he's talking about it's really about lung microvasculature and their interaction with the lymphatics. And I'm thinking, wow, we really are poised to understand a lot of things better with this pandemic and with our own patients' care by understanding the lymphatic system. So I don't think there's ever been a better time in history to be armed with the knowledge that we all have. So with that, we have to just think about the numbers of our patients, though, and just talking about cancer here, and I don't mean to hold anyone else out, but really that's my goal tonight, is to really talk about what we can do in the oncology world. And to just know that right now in the US alone, there's 600,000 people trying to get chemo right now. Some of them may have had to stop getting it. Some may have alterations in it. We have 1.8 million people getting diagnosed. And I said to a colleague earlier today, I can't imagine the pain of hearing those 3 words. You have cancer, and now to hear it in light of this pandemic. So we really have people that are going to be navigating challenges that are just almost insurmountable, it seems. And with that, even the Lymphedema Treatment Act, Heather Ferguson's group, wonderful that they've already done a survey to find out what people are having problems with. And you can see the highlighted things are just my condition's worsening. I don't have money now. I'm not going to be able to get garments. I'm starting to have complications, maybe infections. I have a friend right now who's worried that she may have to go into the hospital for the first time in 16 years from cellulitis, and she's petrified. And right now, we don't really have the space. I have colleagues who've told me they've gotten transferred to other parts of the hospital. And so with that, everyone, companies, hospitals, networks, everyone, sports teams, everyone's adapting and changing. And right now, for us as therapists, we're really having to be able to get into people's homes virtually. And that's where I think we're hoping by the end of tonight to have some ideas with. So with that, our patients are even being triaged. All of these, I did put the link there. Feel free to take pictures of any of these so you have them. But you can go and find out what the surgeons are doing. It's not just the surgical oncologists and breast surgeons, but actually the plastics and reconstructive surgeons have had to make significant changes in what they're doing. We'll talk about those a little later. From that perspective, though, this is really the highlight, is the catch-up of all the care that's getting deferred right now. It's going to come back to us at some point. So my clinic owner, we've all been furloughed, but she says, no, I know I'm going to be able to bring you guys back. And I'm concerned right now about that surge of illness and especially lymphedema to come if we don't start to get to it. So I don't know if anyone else has heard any of the work of Abhijat Naskar, but he's a young guy, and I just love how he thinks. And he had some very nice quotes out here about the pandemic and how we're coming together. And so many other philosophers and different people, medical people, have talked about this, that, boy, this is really pulling us together. But we are going to make some mistakes on this. We're going to have to try things. We're going to have to be able to turn on a dime and make changes. But if we do it all and we do it working together, we're going to be able to do it. So I actually looked in what our different professional organizations are writing. And up in Canada, this came out of an editorial. You'll see most of it's in French there. But they really talked about therapists getting involved really on the front lines with COVID-19. But it's going to have a trickle down. We're going to be needed in every area. And we really do have this moral imperative to act. And, from the nursing world and everywhere, I've heard colleagues say, I'm so concerned. I had a patient just call about cellulitis. So, I'm worried about my patients and their fall risk. And I'm worried about how my patients are going to be able to do their prehab that we would typically do in their surveillance care. So I've really declared my 3 major priorities through this pandemic. This is what I'm going to do for my patients. So I hope you'll hear some of my rationales for this and encourage all of us to be able to really prioritize some of these issues. And this year, according to the American Cancer Society, based on their numbers and some quick math, that 1 out of 5, and I'm using the low estimate, women after breast cancer will get a chronic lymphedema. That's 55,000 women. That's a lot of people. And so with that, we have to be prepared that many of them aren't going to get the same care that they would normally get if we didn't have COVID-19 going on. So I think those numbers are going to be higher. So this next, I have to use the right thing to advance the slide. Sorry about that. So this next slide is one for the fall risk. And if we just take some of these numbers about our knowledge of fall risk, at combined sections this year, my colleague was saying, she even thinks 1 out of 4 is a little low. But if 2 out of 3 breast cancer survivors are over 65, we have upwards of 500,000 patients at risk for falls. No one can afford to be in the hospital right now with a broken hip or broken wrist. We already know how surgeries are getting triaged, and obviously that would be an emergency, but maybe not a risk. But they just can't afford to be around sick people. The nurses know, this was the Oncology Nursing Society, the fear is real everywhere we go. And it's not just for our health, but this is really what a lot of it's about. This is ripped from the headlines right from Johns Hopkins Bloomberg School of Health, Public Health. And one of my favorite researchers there that I'll talk about in a moment. But this financial toxicity of breast cancer, we cannot ignore. It's already bad enough, and it's only going to be magnified with the pandemic. So I'm going to just point out 3 studies. One was from back in 2009. She et al. Talked about the mean cost of breast cancer-related lymphedema on top of breast cancer. It's about $23,000 extra a year that the system has to absorb. That's not the patient per se. When it comes to the patient, though, Dr. Dean, whose lab is at Hopkins, the Dean lab showed 112% higher out-of-pocket cost. That's not 12% higher. That is 112% higher. And you'll see later on, that's roughly $2,000 a year. No one has that right now. Nicole Stout, who's was one of my original instructors for lymphedema and also a colleague at Penn, and I've just watched her career just be so full of some of the best data that we have out there for prospective surveillance. And she saw about $700 versus $3,200. And how are we not making that connection on how important it is to do prospective surveillance? So with that, this came out of HuffPost the other day, and they're talking now about all these workers who were living probably even less than paycheck to paycheck. And that toxicity, again, is probably logarithmically getting increased. And so we don't have even the sick time or the extra $20 for a copay or the extra $90 for a sleeve. And this is really going to add up. So what I'm thinking at this point, I'm furloughed right now, is we may actually have to look into our core values and the core value of social responsibility and possibly do some pro bono care right now. For those of us who still have jobs, it may be great because we won't have to do that. But for the rest of us, we're going to have to reach out. We're going to have to get to our patients and perhaps open a day when we can do some virtual prehabs if we need to for patients, whatever it's going to take. But I think we have to look through these and really say, gosh, how am I going to contribute to this right now? And again, I'm going to go back to the Queen again. I was so inspired by her speech that deep down, we know what the right thing is to do. And, this came from the Canadian Journal, again, with their editorial. And I really do think this is so true right now, that we have to say collectively, if not the collective us, then who, and if not now, when. So that's why I'm saying we have to go back, like the title of the talk was, and meet this unmet need now and not 6 months from now when everything, the acute essence of this is over. We do know that the National Comprehensive Cancer Network knows that this is impacting everything domestically, worldwide, every aspect of it. And we have to keep that communication open, which is why, again, I'm so grateful Tactile has me talking tonight, and really remain flexible. Already, organizations are coming together from in Britain to LSN and then Learn here in the US. They've already mounted a response to this with guidelines for the lymphatic disease community. So if your patients haven't seen these, please make sure everyone has a link to this. I think it will allay a lot of your patients' fears. And I just want to, pay tribute also. This is getting very personal. For those of you who knew Pam Ross from Learn, who passed away on April 2nd from complications from COVID-19, this intersection is just too real. And so we really need to do anything we can right now to help our nonprofits like Learn and like Lymphedema Treatment Act. They are really going to be the vehicles to get information out. So with that, this is this new reality that patients have. This is just a small little look at what the priority is for surgeries. You can actually go to this. I have a copy right here. I'm not going to go through this tonight, but it's, you'll kind of see me holding up this. It's got all the different types of things that are getting prioritized. So instead of trying to memorize it, it's a working document that this may change by next week. So you can go and download that. And if your patients are concerned about, if they're going to be able to get reconstruction right now, the answer is most likely no, especially autologous reconstruction. That's not going to happen right now. Emergent things will happen, but we're going to have to really communicate with our teams to say, hey, what am I going to do with this patient now who had part of their reconstruction but isn't going to have the rest for a while? So we're going to stop here for another question. How many of you were or are still taking pre-treatment baseline measurements for breast cancer patients, specifically some type of girth or volume measurement for lymphedema? So I'm going to give you a minute or two to work on that. So since you can still listen to me at the same time, this again has been one of my kind of life's goals, is to get everyone doing this. My hospital, I don't know if anyone's here from Mercy, where I used to work in Baltimore, but we had a wonderful program where the majority of our patients came in to do this. And it's really critical, and I'm going to show you some of the data as to why it's critical that we actually get these baselines. And even with the pandemic going on, I think we've got some creative ways to do it. So let's see what you guys said. Okay, oopsie, I may have done this wrong. Yeah, so here's where you have to say yes or no. I'll give you another moment there. Sorry, this is our first time doing this. So if you've been taking them, I'm going to move along, but still it's a yes or no. Have you been taking the measurements? Awesome. Oh, that's amazing. So it's really good to see that 75% of you are still getting these measurements. It is critical that we get them. If you're not doing them right now, I highly suggest that you reach out to a colleague someplace and figure out how they're still doing it. It's going to be critically important, or else we won't be able to make good decisions in the future for our patients. And so the screening was recommended by all these different organizations. And that little cup you see there actually represents the 83 milliliters that Nicole Stout's early preoperative assessment for the early diagnosis and treatment of lymphedema from back in 2008. They were able to measure 83 mil change in a limb with a pyrometer. And so this is not a lot of fluid. And we have to understand that these early symptoms are the ones that, again, many of us have been trying to treat throughout our career and not treat a large swollen limb. So with that, our pre-pandemic model of care was what a lot of you were doing, which was someone gets diagnosed with breast cancer, we have some kind of prehab, which is great, and we have the option for early intervention. Unfortunately, I've already been told by a lot of my referring providers that right now that's not happening. And so this is what is happening, that the medical care, again, is getting triaged on not just the oncologic level, but on the surgical level and even on the surveillance level. And they know that these delays are being created. And so it's not just with surgery, but it's with chemotherapies are getting changed, radiation is getting changed. And those referrals to PT/OT right now and survivorship issues are considered kind of category C, and they are not a priority right now. So what they're anticipating, again, is not only extended recovery times, but a financial toxicity, and then also later stage for us of lymphedema and other impairments. So with that, one of the problems of not getting any kind of pre-operative or pre-treatment baseline is, as Dr. Chaville said, this is way back in 2007, is how do you know the difference between a treatment side effect and a pre-existing problem? And so the hope is that we can start to get that so that this is what we don't see a couple months from now. And again, when I see an arm like this, to me, that's a failure of whatever system we've had. No one should have to come to us with an arm that's swollen. So this is, I think, our template for doing this. There is a wonderful article you can get, and it's actually open access. It's through the PT Journal, and you see the reference there from February 2019. And this was a group up in Canada that looked at having patients do their self-measurements and surveillance, and they found that patients can do this. And I think if we can take this article and look through it and come up with some ideas that will translate well to telehealth, that we shouldn't have any problems having anyone do this. And we may, again, need to collaborate to get all the tape measures that someone can use on their own. I think tactile, I think you guys have those. Maybe you could send us some. And we're going to reach out, and don't be afraid. I did send an email out to one of the authors, to Dr. Campbell, and I haven't heard back from her yet. I don't know if they're in their offices working. I'm going to reach out on Twitter pretty soon. And we have already connected with some other colleagues to say we could very easily come up with a template that we could all use and share, so that after this pandemic has gotten out of the acute phase, we may be able to mine some data from this to actually show that this works pretty well, and it's a new path that we could take in the future. My hope, though, is that we get to this type of early intervention where this is as swollen an arm as we see. So the reason I'm so concerned about this goes back to what I was talking to you early on with Dr. Mortimer and Dr. Roxon. And it's that researchers really know that lymphedema has the cellular molecular underlying immune dysfunction that really has to do with inflammation. And that is what is set off during the early injury, whether it's from the cancer itself, or if it's from the surgical and or chemotherapeutic interactions. And so we know there's this dysregulated adipogenesis, and we have, obviously fluid dysregulation as a result. And by the time we're seeing the problem has been here for a while. So my hope is that, again, by having the early intervention and not letting this get lost over the next couple months, that we can get to these things earlier. Because right now, again, the lymphatic surgeries are also not happening. I've spoken to a number of lymphatic surgeons, and they said absolutely they're not going to be able to do these for quite some time for a number of reasons that we don't have time to get into. But this quote from Dr. Hutchison, who's a PM&R physician out in Minnesota, she said this a couple years ago, and it's always stuck with me. And she was so tickled when I asked her if I could use this quote, because I said it really summarizes everything we know about lymphedema and why we need to get to it early before that tissue starts to change. So I love that. And I often talk to patients about, I don't want your soft tissue matrix to change. And that's why we want to get to it early. And according to the study from Dr. Campbell's group, patients were not anxious by this. They did not see increased anxiety with patients taking their own measurements. As a matter of fact, they felt like they were able to do something for themselves. So with that, again, with us being priority C, surgeons aren't necessarily going to have buy-in right now when you're asking them to get you their patients. We know the resources are scarce. We need to limit exposure of patients. And so with that, it comes to my second priority, though, of how I think we need to use telehealth, and is to really prevent cellulitis. Most of you probably know who your patients are who really struggle with this. I've made a list, and I've reached out to all of them to let them know that we are going to have a telehealth option, and to perhaps, talk to their provider about making sure they have their antibiotics at home and ready, so that it's not happening on a Friday night like it always does. We have to limit their exposure to going into emergency departments and also the expensive care. And so this is one area where I've also looked back at my patients who maybe have had more than one cellulitis and still didn't get something like advanced pneumatic compression device, like the tactile device. And so I've looked at that because of some of the research out there. Now, this slide was pretty much about the decreased cost. Even in the cancer cohort and also in the non-cancer cohort, they were able to see a nice reduction in expense. And that meant people not having to go out to outpatient visits as much, not being hospitalized as much, not using as much therapy. But the thing I really want you to look at, and since I can't use a pointer here, I've blown this up in the next slide, is look what it did with cellulitis. Over the course of a year, patients using advanced pneumatic compression devices had tremendous decreases in cellulitic episodes. This has been one of the reasons I started using these devices years ago. Once I had that first imaging with ICG, I said, gosh, this makes sense. You know, we have to get this moving for our patients. And when you think about cellulitis, it's got that biological basis, right? It's this immune dysregulation that's in this area. And it is very costly to treat. It also puts them at risk for further cellulitis. You can read all the other things. But the one thing I think a lot of people don't realize, if they haven't seen this like firsthand with an ultrasound or something, is that when someone's in the throes of a cellulitic event, those lymphangions, in the words of my dear colleague Alex Wen, a surgeon down in Texas, he says, it's like taking turning a lymphatic into a lead pipe. He's like, you just make it this non-compliant vessel that can't pump anymore. And so we see that downward spiral. And I think it's not only potentially life-threatening if they get septic, but now in light of COVID-19, it could be doubly life-threatening, right? They could be at risk having to go in to get care. So this is really something I'm paying attention to. Now, this next slide is going to seem confusing, because why am I showing you legs? Well, for everyone who's taking pre-op measurements, I hope you're also looking at patients' legs. This is something we started doing at my hospital, and we found a lot of people who we thought their risk profile got elevated by already seeing if they had swelling in their legs. It was also nice in the future because if someone did have a DVT or some other problem down the road, we had baselines. And you can see these two women came in for breast cancer treatment, and they both have other types of edema. The one woman actually turned out she had both a phlebostatic but also primary lymphedema combined with obesity. The other woman had lipedema, some venous stasis problems, and a total knee, some orthopedic issues. And so these are complicated patients. So I'm going to show you one other study that, again, is really impactful. And this is for patients who may have more of that phlebostatic edema and or who may have had ulcers. So again, we would find patients who didn't just come in for breast cancer with no other problems. And in this case, when we can see an 81% reduction in cellulitic episodes, it's really important that you find these patients. This next slide always pains me still to look at this picture. And this was one of my patients. This is her leg. She was a woman who really had breast cancer twice, was in for her second reconstruction in the hospital, not my hospital, but was complaining that her legs were bothering her. And the next thing you know, she has the worst cellulitis ever in her life. Now, she has primary lymphedema of her legs. So, of course, she had lymphedema of her arms, too. But this is just terrible. She spent 8 extra days in the hospital. She said the bill was something like $60,000 extra dollars. But even in 2011, the average price for a complicated cellulitis was $40,000 to $80,000. And right now, we don't have room in our ICUs for these patients. So again, this has got to be an imperative that we go after tonight and really look and say, hey, who are our patients? Do we have them on the radar? And back to Dr. Dean's lab. And that's her, you can go to the drdeanlab.com there if you want to see the other work she's doing. She's doing a lot of work with healthcare disparities. It's just amazing, amazing work. But this is where that $2,000, no one has that right now. So we have got to make sure that our patients aren't losing productivity if they even still have a job. They may have to do childcare now that none of the kids are in school. They cannot afford to be sick with cellulitis on top of their lymphedema. So with that, our treatment pathways that we've been using for years, and these are well-defined, they may not work now. I've already heard a lot of clinics having to cut back on their CDT, not being able to do 5 days a week. They don't have the staffing and they're not taking new patients. And so I'm going to propose, again, sort of an adjustment to this. And this could be the possible solutions for not only self-surveillance, but ongoing care. So you can see we still have to start somewhere with that telehealth visit to get some education and a baseline, and then have their self-report trigger further care. And that could be directly to us or through their providers. Then that telehealth visit, that could be, and that is where I've already done it this week, actually a couple of days ago. I did call my rep and say, hey, I've got this patient. She's not going to be able to come in now. Can we get her set up? And they were able to do, I guess somehow the device got to her house and did a demo, and the patient's insurance was able to, with my notes, and that be able to get her a device. And so right now, that's going to be her plan. She can't come out and see me. The next step is we're going to look at some garments that she may be able to get. We still have our DME are still working, but on a very limited basis. With that, I'm going to be able to do the ongoing, whether it's an e-visit or a full-blown telehealth visit with her, and that's when we can do the exercise. There are so many opportunities, and so many groups have offered free exercise programs online, and we have to maybe make a comprehensive list of those so we can share that. Again, not reinvent the wheel, but let our patients go out to the internet and utilize vetted groups that we can have. And then obviously, I want to see these patients in the clinic when it's safe for them and myself. So these are what, if you haven't seen the devices, this is what the bilateral leg treatment looks like. And then this is the unilateral arm and trunk. Both are treating the trunk there. And what I'm really looking at these devices is I can't telehealth, hands-on care. So this is something that can physically manipulate the tissue. And I'm looking at this. I'm looking at using a lot of other tools also, everything from kinesiology tapes to edema wares that channel fluid, to micromassage garments that have a little flexibility in terms of sizing. Patient learn some self-bandaging. They can use tools like their chip foam garments. And anything that I can do right now to create those differential pressures and also get that lymphatic fluid moving. Obviously, exercise is part of that too. So now we're going to come to our third and final question, and that is, how many people have read this really group of articles that was published in Cancer? And the link is there, so take a picture of that so you have it. But it's really easy. If you just search for Cancer April 2012 supplement, you'll find it. And this was a group of about 12 articles that were all about the different needs of our patients. So I'm going to go to the poll question now. I'll keep talking while you answer this. But again, if you've read all about this prospective evaluation from the Cancer Journal, because if not, that's going to be one of your homework assignments during this whole time. It's just one of the best sets of articles I've ever laid eyes on. And it has your path for how to set this up if you aren't already doing some things in your facility. About 25% of you didn't have a program in place yet, and they don't have everything to do that. So let's see what the numbers are looking like. Oh boy, okay, so the Cancer Journal is going to get a lot of people hitting that this weekend. And what's great is you can download almost all the articles, and again, it should really help set you up for understanding this is what it was talking about. It was the call to action for all these different aspects. And so this is what I'm hoping, and again, I've already talked to some of you about, is let's set up some type of telehealth evaluation that we're all doing some of these things and finding clever ways to be able to do them through a not in-person visit. Because this is really what it's looking like for a patient. It's not just upper quadrant issues anymore. And what's really scary is that the Pulling Through study, which is, again, another one of my heroes, Dr. Catherine Schmitz and Dr. Sandy Hayes and all the other people there, but those are just the two I personally know and saw this year at the ISL down in Argentina. And, we were talking about this study again, that this is heartbreaking, that 6 years out, 63% of breast cancer survivors still have one or more of these fairly major complications. And again, I think our numbers are going to increase if we don't do something about it. So this is where we're talking about the Preop baseline, why it's so important. I was thrilled to see 75% of you are getting some kind of number, because the group up at MGH, Mass General up in Boston, they have done tremendous work and contributed so much to this field in terms of our understanding of this. And what they found is they were using a parameter. If they didn't have a Preop baseline, they were under and over diagnosing patients. And really what it looks like is this, is that they already know 20% of people have some type of asymmetry. Well, 11% of those people had a 5% asymmetry already. So right out of the gate, it almost looks like they have a problem. And so we're going to make that cognitive error if we assume that their arm was bigger or smaller before. I've had patients who have a smaller arm that still has lymphedema. I know many of you have had that. And so without that knowledge, we can't, and I say it's impossible to really know what's happening. So if we do anything, even if we use that other article and use it as a guide for patients to take their own measurements, something will be better than nothing. So it's really critical that we start to do that, because again, our prospective surveillance model has so many great things for the patient. You know, we can get exercise going. We can get to any of these impairments before they get bad. But right now, if we don't even have a baseline of some sort, we're not going to be able to do that. So it's really important that here are just some of the things that we obviously get in there. We were talking today about clever ways to do a balance and gait assessment for safety reason. If someone's home alone, they can set up their camera and you can put them in a corner. We said maybe not be able to do any gait evals as well unless they had assistants in the house for safety. But there's all types of ways that we're going to be able to figure out some of the baseline with our telehealth. And hopefully once they leave our visit, that we will have guidelines for them. And whether that is just shelter program that they can go online of our vetted sources, we're going to be able to give that to them. So I'm super excited to start to work on this together. So with that, if you haven't read a lot about standardized prospective assessments, these are a number of different programs. Kohlmeyer et al., many of you may know Louise Kohlmeyer and her group over in Australia have one of the best programs. What they're doing is they're into lymphedema so early. Kilgore et al. Was a group at University of Kansas. Dr. Whitworth and run a great little program in a private breast surgeon's office in Nashville, T. And then you can read sort of a good review of this. There's actually a journal called Gland Surgery. I know you're all going to run out and get that. But Gillespie's article was a really nice review of many of these different things. And so it's a great time to really read up on some of these if you can. So with that, I'm going to go back to, remember She's study, where $23,000 is what it costs for the system to kind of take care of a patient. And this is a shout out to one of my friends in the audience who was asking, like, how do I get my hospital to spend the money on doing a bioimpedance surveillance, like with the LDEX? And I said, this to me is a no-brainer. It's the cost of what it would take one woman to get cared for who has chronic lymphedema. And so you can call, that company and ask more about that. But it's really unconscionable that we're looking at the dollars and cents when we see how expensive this is going to be. So this next, I can't believe I actually found this cartoon. It was so apropos for what's happening right now. Because really, we can't ignore reality. That's not working, is it? We can't put our head in the sand. We have to really go for that change, because those 55,000 women who are going to get chronic lymphedema this year, even under the best of circumstances, that $2,000 for each of them is equivalent to $110 million. And we've got to be able to do better. Again, when we look at it that perspective, and it's not just about what's happening with our one patient, it's happening to the whole system, I think that can start to make the case for doing better on this. So then we have to look also at the fact that 2 out of 3 breast cancer survivors are not meeting exercise guidelines. We don't need to look far in the news right now to see the underlying health problems are why a lot of people are dying from COVID-19. It has to be all those other quality of life kind of health issues that come with, like poverty and with not getting exercise, not eating good food, having a stressful job or working 2 jobs. All these different reasons why people can't get the exercise. And we have to do something about it, because right now we know that, again, this pyramid is from when things are working well, that still the bulk of care is the patient. Like, we can talk to them about exercise, but we don't go to the gym with them, right? They have to go and do it. We teach them the lymphedema care, but they're the ones that actually have to do it. And right now, that level is getting even higher and higher up on that pyramid, because right now we can only care for the most acute patients during this crisis. And so with that, I think if we look again back to the literature, and these are some things you can go back and look at. Dr. Jane Armour's amazing work in self-reportive symptoms back in 2003. She was already saying, yeah, women with breast cancer-related lymphedema know they have a problem. They can sense it. There's Stout's work in 2008 and other groups saying, yeah, early intervention model works. If you don't know who Mei Fu is, she's another nurse. Dr. Fu is just, her team has done remarkable work with symptom report and even using artificial intelligence. So the computer can actually predict and actually diagnose who has lymphedema. So, we may be getting to models like that. And we can see in 2019, Prepp et al. Said, yeah, we've got 10 years of history showing the validity of self-reported symptoms. So even right now, if that's what you have to do with your EVisits or work with your providers so that they're asking one simple question for your patient, like, do you have arm heaviness? Does your arm feel different? Do you have numbness or tingling? That could really help us get to these patients earlier. And so self-report, again, take a picture of this, get it back to your team, tell them how important this is, and we should be able to work this into everyone's program. So I'm going to quickly look at the social science work, and that is patients need personalized data to have it be relevant, to make choices and take action. It doesn't work any other way. If we use fear, patients don't work off of that. They need to believe they can do something. And so with that, I really think we can do this. So that's that report. Again, we'll get you the reference for that. But I think right now in this space, we can do this. We can all read this article. This is a free article that just came out this year. Again, look at all those names. I think I've mentioned most of them tonight. We know exercise is actually medicine and oncology. We can totally do that with telehealth right now. Get yourself a copy of the ACMS guidelines. These talk about the research and how important it is for patients. So you can, every single one of your patients can get a copy of this and read it themselves. We can break down the cost of what one of these devices, any advanced pneumatic compression device, the tactile device. I did this math myself with a patient the other day saying it's not going to really cost too much. This is going to last for years. One of my patients has had her pump for 8 years. And when I look at how much my patients are paying to come see me at $140 a visit, that's only 35 visits. And they're going to be able to do this every day. For those of you in hospitals, find out how much your care costs. This was based on my former hospital, and that amount of money would cover about 2 weeks of care in the hospital-based clinics. It's expensive. And so really, remember the old MasterCard ads? I couldn't put their logo up there, but really the cost for pump right now versus the cost of being hospitalized during this pandemic, we just can't compare it. So with that, we have so many opportunities. We can risk stratify our patients. We know the patients who are probably going to use that stratification ABC that the surgeons are using, because if it's someone in that A or B category, we need to get to them. We have to create our own multi-D teams that may not exist in a physical reality right now, but they have to be virtual. I was talking to one of my nurse practitioners today. We really have to listen to our patients. Right now, it's easy sometimes to go into the computer, but we had a computer problem the other day. We couldn't get an emergency number. Please make a physical list and ask your physicians and your mid-level providers who may need to write that prescription for you. Get their cell phone number. Promise them you'll only use it for urgent issues. But this really made a difference for a patient the other day. Keep breaking things down for patients. This is just one of the scariest times ever to even have something mild going on. I can't imagine when it's something really serious, but just be patient with them and get the lymph system moving, whether it's with exercise, with an advanced pneumatic device, with a patient doing their own MLD. We've got to get to these people early and give them these tools. So with it, again, embracing the telehealth and this technology that we have. There was a great article, someone was talking, we may have sensors we could give to patients soon that could help them know when they're having problems. I can't wait for that. We have to leverage all of our relationships and connections with each other. And we really have to start collaborating with other groups that have already got some of these great exercise programs, especially, and many of them are offering them for free right now. So I love this quote from the NCCN, just that we are going to prevail. And, this moment that we have together we're never going to forget it. It's going to be ingrained. And as the Queen said, I want to thank all who are staying home. Don't feel bad if you're stuck at home right now. If you're at home, you can coordinate with people like myself, with my friend Kathleen out there, with many other people. I think, Jane, you're out there someplace. Let's talk together, because I think together we can really do something, especially with our resources of those of us who aren't on the front lines. And I do want to leave you with just something to make you feel a little better, because this is hard. This is the hardest thing I think I've ever been through. I've been getting out in nature, and for those of you who follow me on social media, that's where all those great pictures are coming from. I found this one poem that I was just so impacted by, that don't forget, just take it one step at a time. Don't forget to take some rest for yourself too, and compliment yourself sometime, knowing that you're doing the best when you can. And, you know, the beauty, as Abhijat and Askar said, is, you know, we have to make sure we have each other's back. We're going to get through this catastrophe, but we just make sure we don't leave anyone behind. So I want to thank all of you for coming out this evening. We're going to open it up for questions. You can certainly get hold of me through any of these ways. Probably the best one is my Gmail, or text me. I'm on Twitter, Instagram. And I just want to thank Tactile for giving me this platform tonight to really just get the ball rolling, to get us all connected. And everyone, please stay safe out there and keep doing the amazing work that we're all doing. Thank you.
Maureen, thank you so much for being here. We are just incredibly thankful for your mind and jumping to action, and to all of the attendees, we are genuinely grateful for your time. It really shows your initiative and your dedication to patients, that you could be doing anything with your evening, but you're looking for ways to make an impact now and in the future. I have been going through the Q&A. I have some questions here for you, Maureen. One is, to your knowledge, is first-line defense of cancer treatment, i.e. surgery, being slowed, and are patients moving to more like chemotherapy, radiation, or taxane-based chemos prior to surgery as a result of COVID? And if so, how is this impacting patients?
That's great. Super question. You know, I would say everyone, again, make sure that you download a copy of these guidelines with kind of their stratification with the 80. They've really gotten through the first version, which came out about 24th, actually, almost 3 weeks now. Priority A, for example, would be a newly diagnosed patient who has a certain type of tumor that they are going to go, you know, right after that. But many patients, for example, who have a tumor that would be more suitable for doing some endocrine therapy or something, they're going to be able to hold off on some of their surgeries. And so the timelines that they're looking at, for example, I can look right here, is, you know, things like evacuations of hematoma, incisions, and draining of abscesses. They're going to get to those right away. Patients who are just finishing neoadjuvant treatment, they're going to have to complete their surgeries sooner than later. But for example, they'll probably try to do more lumpectomies than mastectomies, because a lot of times with breast conservation therapy, that mastectomy could be considered, you know, too much of a risk at this point. So I think what we're going to see is a lot of people having some of their surgery. Again, certainly none of the more complicated reconstructions. We may see tissue expanders still be put in, some direct implant surgeries, but anything that's going to make a patient go in the hospital, they're holding off. The same with the oncologic care and the radiation care, is they're looking to see certainly, for example, I think if someone is stable and has, let's say, like a DCIS, they're not going to do their radiation now. So go to those guidelines, though. It's a great resource, and I hope that answered that question enough.
Yeah, absolutely. I just wanted to say to the attendees who are submitting questions looking for links to resources that were shared, we will be sending a follow-up email using your registration information, it sounds like, to provide some of those links to you, because that's going to be the easiest way to get them to you. So if you feel like I'm ignoring your question, I'm not. And then, Maureen, for our next question for you, how are you reimbursed by insurance for pre-measure evals, knowing how important those are?
So I'm speaking now of someone who is now working as an independent contractor in my private practice until we can all get hired back. And even before that, in outpatient, non-hospital based, I'm out of network cash pay. So my patients unfortunately pay $140 to see me, whether that's an eval or a treatment. And so some of them have out of network coverage, and we haven't had any problems with them getting reimbursed. And when I was at a hospital, now this was in Maryland, I can only speak for Maryland, but we had no problems doing preoperative assessments. We used to do 200 to 300 preoperative assessments every year on every insurance and did not have issues. So I think you have to work with your payers for that. And we just use the breast cancer code. And we almost always found an impairment in someone. I don't think there was ever a person who got through a prehab eval that didn't have something going on.
Thank you. This attendee is asking, are you referring for a pneumatic compression device for all medically appropriate patients with subclinical lymphedema?
So that's a great question. Sorry, I almost pulled up my earpiece. So when you say subclinical, I would ask, how are you measuring that? I am lucky I have bioimpedance spectroscopy. So I have the LDEX, and I'm able to measure people very early and see very early changes. And also I have, preoperative measurements with volume also. It all depends on what else is going on. And so pre-COVID-19, I work very closely with a lot of plastics reconstructive surgeons who are doing, the very complicated DIEP flaps and things like that. Sometimes they're having to be delayed. And certainly if someone's starting to have subclinical problems and they still have 2 more surgeries ahead of them, radiation, things like that, we're getting devices as soon as I can. Because I'm really looking at it is they're going to need this for a while, even if it's for the next year or 2 to get through all their surgeries and all the, you're now post-op, now you're pre-op again, you're post-op again, you're pre-op again. And it's great because a lot of the patients have met their deductibles because of all the surgeries and everything. So I err on the side of getting it sooner than later. And just this year alone, it really came in handy because I had a patient who had a failed reconstruction and finally after 8 years decided she wanted a breast and actually had this device, and we used it pre and post-op, and it made all the difference in the world.
That's great. I'm sort of combining a few questions on a theme here, so bear with me. But so one of the attendees, as just her own recommendation, she says for exercise reinforcement, she sends clients to Lymphistrong as a Facebook group so that her patients can be with their peers. And but then we have several other people just asking, like, what are some exercise guidance or recommendations or sites that you might use with your patients?
So that's great. So right now, just today, I'd have to go onto my phone here, but there was a link that there is some free work that Sarah, let me find her here, Weller's group. Let me see her, and I'll get this. Maybe we could put this on the thing for that we send out in an email. But right now they're offering free exercise for patients. I think it's for up to 3 months. And so, they have Instagram live classes. So perhaps free cancer exercise classes. They have one on Tuesday, one on Thursday, one on Saturday. It's just awesome. And that link, we can get to you for that. It's through the TRELOAR Cancer Recovery Network. And we'll make sure we get you Sarah's info, because I just tweeted her today, say, hey, Sarah, I'm going to blast this out to everyone. But there are a lot of resources out there. So I use a lot of online things, and pretty much that's what we do with part of the visit is we go through them. I have one I use all the time that's a little program called Shush's Lymphatic Flow Yoga. It's a seated chair yoga program. It's about 12 minutes long when you listen to all the instructions, and afterwards a patient can learn to do that in like 7 minutes. So I use a lot of online things. And then we also have online exercise programming through our EHR.
Thank you. Again, kind of combining 2 questions. Somebody is asking, what specifically are you doing with patients during EVisits? And another is saying, like, what are practical things we can do during EVisits for patients with lymphedema? And they offer up some examples. They say cellulitis consultation, exercise, garment check, anything else you can think of. So just in real practical, nitty-gritty terms, what are you doing during these EVisits?
Yeah, so, with our different payers, I tried to print out a list of what our local payers are paying. So pretty much, it's the exercise. And I have not billed a garment check. I'm just using the self-care code for that and documenting it under that right now. But yeah, I had a lady the other day who was having problems donning a garment. I had her order one of those little pads to help, and then we did the virtual fitting, and it worked really well. Her only problem, what some patients are having problems with, is they're working off of phones and they have a hard time holding the phone up. So someone please come up with a good holder for our patients to get, and we could send them out to our patients. Yeah, so we're keeping our visits right now to 30 minutes for our telehealth visits, and so far they said they're getting reimbursed. And I've switched to a model. We're doing a cash-based model right now of $45 for some of the patients who are out of network and just want to do straight up cash and not worry about reimbursement.
Thank you. And then I guess just sort of a word for me / a lot of questions around differentiating between EVisits and telehealth, and then a lot of questions around billing for EVisits and telehealth. And one of the links that I think we'll send out at the end of this is from apta.org, because they actually on March 18th, published an FAQ for PTs about billing for EVisits. That's not something that we can advise for. They are different. CMS certainly has guidance, but other payers, it's payer by payer. And so I don't think there's broad national guidance we can give on this call.
Yeah, and I unfortunately can't give you that. All I know is the owner of my clinic and our business manager, they have been on the phone and doing so much work over that. We have a daily meeting with, now that we're all independent contractors, we have a 12 noon telemeeting that the group comes in, and every day we're getting new guidance on it, or we're seeing another provider that's now paying for this or not paying for that, or we have to use the 59 modifier. So I wish I could give you more information on that, but that's not my expertise in terms of the billing, and I'm having to work with my business manager again and my clinic owner to really do that and get it right.
That sounds great. And yeah, I would just encourage people to seek out their society for their professional affiliation for guidance, and then, yes, work with their business managers and with their local insurance companies for billing for care like that. With that, I think we've reached most of the key questions. We are at 7 p.m. Maureen, you're just getting through the questions. Lots of love from people. They're just appreciating the information, and lots of hellos from those who know you. So again, we just appreciate your time, and to everybody on the call, thank you so much for joining us.
Yeah, thank you. And if there's further questions that we didn't get to, I'm just seeing some of them come through. I'm more than glad to try to get to some of these through, email, or if we can send something out. And yeah, I know, is it okay if I just talk for 1 minute about a few of these? Just about, we'll get the references to the articles, because I had shorter references on the slide, on the slides. And I think
we'll definitely be sending out a summary with some links, because that was a frequently asked question in varying forms, looking for some extra time with the links so that we could get them. So we'll absolutely do that.
That sounds great. Well, thank you, everyone, again. And, if you had another question we didn't get to, you have my social media contacts. Please reach out to me. I'm not seeing that many patients right now. I have a lot of time and would love to on this. And again, Tactile, thank you so much for giving me this opportunity for really the lymphedema community to connect together. It means a lot to me personally and on behalf of all of our patients. So thank you, and everyone stay safe.